Is he here? Is anybody here? All right, you've got a bill before the committee. Senator Suderline.
All right, would you like me to stay or move?
You can do whatever you want, so.
Thank you, Mr. Chairman. I've got Senate Bill 1426. This is dealing with paramedics being able to operate under the protocols, but we've got a line amendment that I think if council reports the entire amendment, you will now have basically the entire bill.
Mr. Chair, the new section will now read, persons who are employed or engaged at a medical care facility as defined in 32.1-3 who have a valid emergency medical services provider certification issued by the Board of Health as a requirement of being employed or engaged in the medical care facility within the scope of such certification pursuant to an oral or written order or standing protocol to administer drugs and devices at the medical care facility.
So, like I said, you now have the bill. We also, that's Amendment 2. We also have Amendment 1, which I guess I'd like council just to share that as well. That is,
Mr. Chair, on line 5, after the semicolon, we're going to insert emergency medical services providers or.
so I'd like to move that we adopt those amendments.
Second.
All right, all in favor say aye.
Aye.
All opposed, no. All right, those amendments are adopted.
Well, you basically now had the bill read to you about what's being changed in the law, because that's what the amendments were. We've got some of our folks that would like to share why the hospitals think this would be beneficial to Virginians, and I'd ask if they would like to come share.
All right.
Morning, Mr. Chairman, members of the committee. Brent Mullings with the Virginia Hospital and Healthcare Association. I want to thank Senator Suderline for helping us with this legislation, bringing forward. Really what it is doing is putting into code existing practice. Today, the Office of Emergency Medical Services has guidance that addresses paramedics serving in facilities and settings outside of an emergency EMS agency. And gives them the authority to practice within their scope of practice in other settings of care. It clearly states that that is outside of the EMS regulations, and so what we're really doing today is putting into code and addressing this sort of no man's land, regulatory no man's land as it relates to administration of drugs and devices, dropping it into this code section that authorizes various individuals to administer medications pursuant to a physician order. So I ask the committee to look favorably upon this legislation. Thank you.
All right,
happy to
thank
answer
you.
any questions.
Yeah, does anybody have any questions? All right.
Morning, Mr. Chairman, members of the committee. Scott Johnson, representing HCA hospitals. We use paramedics in the emergency rooms of our 14 facilities in the state and have been and like to do that, and this is an important clarification. I ask you to support it.
All right, thank you. Anybody else wish to testify? All right, bill's before us.
Move report.
Second.
All right, we got a motion and a second. If there's no further discussion, call the roll.
Senator McPike,
Senator McPike votes aye by proxy.
Senator Hashmi,
Aye.
Senator Pillion, Senator Suderline,
Yes.
Senator Donovan,
Yes.
Senator Edwards, Senator Newman, Senator Saslaw,
Senator Saslaw votes aye by proxy.
Senator Barker.
Aye.
7 ayes, no zero.
All
Thank
right,
you,
that-
Mr. Chairman.
Certainly.
Mr. Chairman.
Yes.
I've got 2 bills.
All right.
Mr. Chairman, this is SB 932, which addresses the issue of helping our community members who are in need of medication to address PTSD and depression issues, but whose the other medications are not really assisting them and helping them to take care of their critical needs. Last year, I had introduced a bill to decriminalize psilocybin, which has been proven to be quite effective in treating PTSD as well as depression issues, particularly among our military veterans. There's increasingly compelling research coming out of Johns Hopkins, from Stanford, to demonstrate how effective the product is in the treatment of these particular concerns. There are many states that have already moved to decriminalize psilocybin and have seen good and effective results by doing so. Last year, we heard testimony from a wide variety of researchers from our military community, from people who have used the natural drug and found healing as a result of that. This year, rather than trying to decriminalize psilocybin, which we understand was creating a whole new structure for the treatment of the drug, we are asking that we create an advisory board who has the purpose and the charge of examining the research and advising our Secretary of Public Safety, Secretary of Health and Human Resources on the efficacy of the product, on the scientific studies and the research, and also then creating a structure by which we can medically and effectively use psilocybin for the treatment of these different issues such as depression and PTSD. This bill would also change the scheduling of the drug from a Schedule 1 to Schedule 3, and therefore change it to a Class 1 misdemeanor for individuals who use psilocybin. And again, the purpose is to use it for medical purposes only, and so that is the bill in front of us today.
All right. So are there any questions of the patron?
I have two questions.
Yes.
Senator, what this does is just create a board, advisory board, and reduce it from Schedule 1 to Schedule 3. That's all it does.
That's all it does, Senator.
Okay.
All right. Any questions for the patron? All right. Does anyone want to testify on this bill?
I think my folks are sleeping in.
Mr. Chairman, I have a question.
Yes, Senator Donovan.
I'm just curious, as we look at setting up a board, isn't this something that the Board of Pharmacy could manage? Why do we need a separate board to do that?
This is following a model that was set up, I believe it was in Colorado, with a variety of different individuals, part of the advisory committee. And so it brings together the people who work in this field. And we have the members that would be composing it would include public health directors and state health officials, but also then include individuals who are specializing in the treatment of PTSD, such as a licensed physician, also individuals who specialize in natural healing products. So and I hope I'm saying this correctly, mycologist, who is whose specialty is in the treatment using mushrooms. And so there is a specialization that's necessary in this particular field, and the people who compose the advisory board would have that degree of knowledge and specificity around the usage of psilocybin.
All right. Any other questions? All right. The bill is before us.
I move to recommend reporting.
All right. Is there a second?
I didn't hear that.
She moved to recommend reporting.
Yeah, second.
Okay, we have a motion and a second. If there's no further discussion or questions, call the roll.
Senator McPike,
Aye by proxy.
Senator Hashmi,
Aye.
Senator Pillion, Senator Suderline,
No.
Senator Donovan, Senator Edwards,
Aye.
Senator Saslaw,
Aye by proxy.
Senator Barker.
Aye.
Ayes 6, noes 1.
All right, that motion passes, so.
Thank you, Mr. Chair. And if I could, well, I see Senator Vogel's here, so
Okay.
we'll do the next bill later.
All right. That's all right. Yeah. Senator Vogel.
Good morning, Mr. Chair and members of the committee. I have Senate Bill 1406, and this deals with credentialing of behavioral analysts. And it's currently the case in Virginia right now that our behavioral analysts are certified by groups that are not it's not the way we certify medical professionals by one board, as is the case in Virginia and other states. We have a nonprofit that can certify them, and it is certainly the case that behavioral analysts and those who wish them to be regulated would like it to be done through the BACB. And what this statute does is change that so that it would be done through that regular process, and all those other certifying nonprofits would be sort of removed from that process, and it would be one standardized process that then the Board of Medicine would know was qualified.
Okay.
And I know that there are people who are here who
All right, does anybody have any
Like to
questions
comment.
for the patron? All right. We'll take public testimony now. Come forward, please. Yeah, yeah. Yeah, that'd be good. So, yeah.
Thank you. Thank you, Senator
Oh,
Vogel.
hi.
Hi. Thank you, Chairman Barker. My name is Christy Benko, and I'm the Administrative Director for the Virginia Association for Behavior Analysis. And applied behavior analysis is the application of the science of behavior to human services. It's not really a therapy or a bunch of tricks. It's really that.
Can't hear.
Oh, am I?
Can't hear.
Sorry, thank you. It is the application of the science, and it really takes somebody who is, thank you, who is well-trained and certified. And the way the statute is written now, it's very loose. There's a loophole. Anybody can pretty much come up with a certification agency, just a little bit under the requirements of the BACB, and then the next person can come up with one that's just a little bit under, and they can be for-profit entities. It doesn't protect our consumers, our patients. And so we just ask that you close this loophole to make sure that it's protection for the consumers.
All right.
Thank you.
All right, thank you.
Chairman, can
Yes,
I ask a brief question?
Yes.
I think you're probably the person to ask. So is there any other state that does it the way Virginia does it right now?
Yes.
Well, I mean,
Texas?
currently allowing everyone else.
Oh, you mean the way that Virginia does it now?
Yes, the way you don't like it.
I don't know of any at the moment. I do know of, there are lots of states that don't have licensure at all, so
At least it's not our
that I
current
know.
practice
No, I
is
know
not
of states
common.
that are, that have closed loopholes.
All right, thank you, Mr. Chairman, thank you.
Thank you.
Yes, there a question?
Is there harm that's come to patients?
Not at the, I couldn't tell you specifically. Right now, there are not very many people who have licenses without the board certification. Our concern is the future. So if people catch on, as they're starting to do, that this loophole is open, then for-profit companies can say, okay, it takes a long time to become a behavior analyst. Maybe you don't want to take that time. Maybe you don't want to spend that money. And they just keep going under and under. So I wouldn't say that there's harm yet. There is the potential of harm, and I think that's why all of the other statutes are written to not have that loophole in the Board of Medicine. It was just ours that was kind of left open. But the only people currently, it's not a workforce issue, the only people currently who have been licensed under a different certification are all out of state, so probably not practicing very often in Virginia.
All right, thank you. Next? Yeah.
Thank you, Mr. Chairman, members of the subcommittee. I'm Mindy Carlin, Executive Director of the Virginia Association of Community-Based Providers. We support this legislation. We see ABA services as becoming more and more used for more and more different types of populations and can be a very effective tool. And so we believe this legislation is going to tighten things up to make sure that those delivering those services are qualified, and that we're ensuring that the people who need their services are really getting the very best from the very best. And so we urge your support of this legislation. Thanks.
All right, thank you.
Thank you, Mr. Chair and committee. My name is Eli Newcomb, and I'm a behavior analyst at a local nonprofit, and I oversee the clinical standards at our facility. The central clinical methodology we use is behavior analysis. Therefore, we employ lots of behavior analysts, and over the years, we've employed a pretty large number that are now throughout the state practicing. We as an employer very specifically seek behavior analysts who have the BACB's credential past and present, and that's because their standards appear to be the highest. Therefore, going forward, that's going to continue to be our practice unless things change. We think it enhances consumer protection, and for those reasons, we submit our support for this bill. Thank you.
All right, thank you.
Good morning, Mr. Chairman. Randy Pearson on behalf of Plan B Academy, which is one of our state's private day schools located in Chesapeake and serving children in Virginia Beach, Hampton, Norfolk, Newport News, and elsewhere, as well as the Virginia Institute of Autism, which serves children in Charlottesville, as well as Lexington, Lynchburg, and Roanoke. We support this bill because we believe it's a safety issue. We want the folks who are working with the children that our schools serve to have the proper certifications, to have the proper training, education to do the work they need to do. Thank you.
Anyone else want to testify? All right, the bill is before us. All right, we have a motion to recommend reporting. Is there a second? Second. All right. If there's no further questions or discussions, I call the roll.
Senator McPike,
Aye by proxy.
Senator Hashmi,
Aye.
Senator Pillion,
Aye.
Senator Suderline,
Yes.
Senator Donovan,
Yes.
Senator Edwards,
Aye.
Senator Newman,
Aye.
Senator Saslaw,
Aye by proxy.
Senator Barker.
Aye.
Ayes 9, noes 0.
All right, that passes.
Thank you, Mr. Chair and members of the committee.
Certainly. All right, Senator Peake.
Yes, sir. Good morning.
Good morning.
How are y'all today?
We're all awake,
Y'all been passing a lot of bills out of here today?
but we're just waiting. We're waiting for you. Yeah.
And until you arrived, everyone.
Good morning. Senate Bill 1054. This is a criminal background check to comply with licensing guidelines, and particularly our psychology interjurisdictional compact, SIPAC, and our occupational therapy interjurisdictional compact, the OT compact. We became a member in January 2022, and those compacts require that you do a background check on people that you're trying to cross license. And so this is just a cleanup bill to get that done. I think we might have somebody here from the...
All right. Is there any questions of the patron? All right, come forward.
Good morning, Mr. Chair, members of the subcommittee. This is an agency bill with support from the administration. This will allow criminal background checks to be implemented for any healthcare compact that the General Assembly passes in the future. And Senator Peake is correct. We have two that are currently awaiting criminal background checks to be compliant with the compact terms, the Occupational Therapy Compact and SIPACT. And I'm happy to answer any questions. Thank you.
Thank you. Anybody else want to testify? All right, the bill is before us.
The bill's before you.
Yeah. All right, a motion to report and a second.
Got to wake this group
I
up.
know. All right.
I did a great job, didn't I?
If there's no further questions or discussion, call the roll.
Senator McPike,
McPike, he might vote aye by proxy, so.
Senator Hashmi,
Aye.
Senator Pillion,
Yes, by proxy.
Senator Suderline,
Yes.
Senator Donovan,
Aye.
Senator Edwards,
Aye.
Senator Newman, Senator Saslaw,
Aye by proxy.
Senator Barker,
Aye.
Ayes 9, no 0.
Thank you, guys. Y'all can start killing some other bills now. Hopefully.
All right. Are there any other patrons? Any other? Okay.
Mr. Chair and members of the committee, this bill is actually Senator Locke's bill, and I am presenting on her behalf as SB 1440. And this is a bill that we've seen before. We had it in front of us last year, but it's an amended version, and it's an amended bill from the version that was continued last session, and also refer to the Task Force on Maternal Health Data and Quality Measures. The task force never put the bill on the agenda for any of its meetings, and that was promised to me and to Senator Locke when we heard the bill last session, that the task force would put the bill on the agenda and discuss the issues around maternal health data and quality measures, and it's our understanding that the task force did not follow through on that promise from last year. So we never received recommendations to amend the language for the bill. So this amended bill was developed from meetings with stakeholders and the Department of Health Professions to respond to concerns over the language. The bill now applies an unconscious bias training licensing criterion to prenatal health care professionals only, and in every other renewable cycle. So it is a very limited bill in that regard. This addresses the concerns about adding extra burden every renewal and about the board net, about the broad net of healthcare professionals as the original bill would have applied to. So we did hear concerns that continuing education should not be a requirement, but that institutions should be required to offer it. The Virginia Board of Medicine already currently provides information and resources on its website and its newsletters on educational opportunities, but regardless of that fact, the maternal mortality rates in Virginia per 100,000 deaths more than doubled from 2018. Which were 37.1 deaths, to 2020, which is now 86.6 deaths. And this crisis demands more than an optional solution. Only a required educational intervention can help us now to reverse some of the tragic trends that we're seeing in increased deaths. We also heard concerns about codifying education, that education should not be codified or legislated by the General Assembly. However, the language in the code to establish continuing education to address the opioid crisis that was due to sunset was extended. An examination of the magnitude and urgency of maternal mortality data also then warrants an equal response. Virginia's maternal mortality rate, where Black women are dying 3 to 4 times more than their counterparts, is worse than the national average, which is 2 to 3 times more. So this is not just another health care crisis in Virginia. It really is a significant maternal health crisis. And so we ask the committee to support this bill.
All right. Are there any questions of the patron? All right. Does anyone wish to testify on this bill?
Good morning, Chairman and members of the committee. Emily Moore with Voices for Virginia's Children. I'm also here on behalf of the PUSH Coalition for Maternal Health. Senator Hashmi really gave you the statistics well, so I'll spare you the additional statistics, but do want to say that Virginia has done a really nice job in addressing some of the disparities in maternal health by creating a postpartum coverage in Medicaid and addressing doula coverage as well. But unfortunately, due to the statistics that Senator Hashmi shared, the maternal health crisis still continues. Virginia's maternal mortality review team found that 51% of pregnancy-related deaths are due to provider-related factors and not underlying health conditions. And so implicit bias in healthcare is a matter of life or death. And so we hope that Virginia will join the nearly 20 states that have adopted these type of requirements for healthcare professionals. And thanks Senator Hashmi and Senator Locke for bringing this forward, and hope that you will vote in support. Thank you.
I have a question.
I've got a question.
you say a lot of the problems is a result of provider issues. So give me an example.
So I don't have the review team's report. We can certainly get you the Virginia Mortality Review Team's report, but their statistics do say that 51% of those deaths are due to provider-related factors and not underlying health conditions. So that would be like implicit bias in this example of having those preconceived notions. There are, of course, reports that say that there are beliefs that Black women can go through more pain. They have a higher pain tolerance than their white counterparts, and we know that that's not true. And so a lot of data has been collected around this. A lot of reports have been done around this, and we'll be happy to
Yeah, I'd like to see that. Yeah, thank you very much.
Sure, of course. Thank you.
All right.
Good morning, Mr. Chair, members of the subcommittee. My name is Sheila Herlihy. I work at the Virginia Interfaith Center for Public Policy, and we are also members of the PUSH Coalition. We'd like to thank the Senator for bringing the bill, and just want to share a statement that my colleague put together. She was unable to be here today, but that the Virginia, this training, which is which is every other training period, so only every 4 years, for practitioners who have direct contact with birthing people, would have a positive impact, as shown in several states which have already enacted such a training. So we ask you to please support the bill. Thank you.
Thank you. Next.
Good morning, Mr. Chairman. Again, Scott Johnson. I'm speaking on behalf of the Medical Society as their general counsel. We are not objecting to the issue of implicit bias, but I wanted to suggest to you and the committee and my good friend a different pathway to get there. We have got in place in the law today that some of the health regulatory boards can designate certain hours in certain important topics like this, but the Board of Medicine does not have that. And I know we're not supposed to talk about the body down the hall, but one approach that's coming to you is to put in statute authorization for the Board of Medicine to designate certain hours in important categories like this, and then in a second enactment clause direct the Board of Medicine to say, of your first designations, implicit bias training should be there. That way you keep out of the code all of this information because it's in a second enactment, but you give the board power in the code. So I don't have that prepared. I'll hand Julia my suggestion, and I'm sorry it was on the fly, but I'm glad to answer any questions and would ask you all to look favorably upon that. Again, it's important, not trying to divert from that.
Senator Newman.
Mr. Chairman, I don't know if it's to you or the senator. What does it mean when it says that you have direct contact with persons who are or may become pregnant? In other words, is that every woman within a certain age?
Right, Mr. Chairman, Senator Newman, the thing if you wrote it to say all licensees of the Board of Medicine has got surgical techs and respiratory therapists and chiropractors and podiatrists and folks other than physicians, nurse practitioners, and PAs. And so I think, not trying to speak for Senator Locke or Senator Hashmi, I think this was an attempt to tell the board, don't do a shotgun approach, just target those people that are treating moms or treating pregnant moms or babies or things like that. And Ms. Barrett is here from DHP. If I got that wrong, she will get me straight.
That's correct. It's restricted just to perinatal. You're correct. It is restricted just to perinatal healthcare professionals, so women who are either pregnant or about to be pregnant.
Mr. Chairman.
Yes.
Just a question for you, Scott. I'm not exactly sure I understand what the board process is. I might have you explain that to me more, but I will tell you I do 35 hours of continuing medical education every year to maintain my certification and my fellowship with the American College. With that, there's always implicit bias training. That's always part of the training. So are we going to, the position for determining best practices should stand with the credentialing societies that are utilized by the hospitals, by the health plans, by everybody else. So are you looking at the board adding to the training that we've already had? Because I think that's where we have to be clear, and this is a really ugly Christmas tree. And I will point out, I hope everybody will look at all of the reports from the Maternal Mortality commission, because the one that is incredibly staggering is the one that talks about chronic disease management. And the reason that women are dying in Virginia is because they are dying from hypertension, obesity, diabetes, and they are not getting coordinated care. There's a budget amendment in this year that I think we're all in support of to look at drawing down dollars to coordinate that care, because as we know, it's really hard to navigate the healthcare system, let alone access other assets that would be social determinants of health to help elevate them. So I have to say, in defense of medicine, that the conclusion that the cause of increased mortality in Virginia resides in bias would be not one that is adequately supported by the evidence, even from our own Maternity and Mortality Review Committee.
Right. Mr. Chairman, I would respond to Senator Donovan that we borrowed some language that I think she advocated for and y'all used back when we were at the peak of the opioid crisis around 2017. And so what we had proposed to put in statute is not an addition of hours, but basically said of the hours of continuing education required on a biannual renewal of license. Doctors are licensed on a 2-year license, not a 1. That any licensee of the Board of Medicine may be required by the board to complete up to 2 hours of type 1 continuing learning activities. That means usually in person at a conference. It's not reading a magazine or looking at something online. In a specific subject area. So the Board of Medicine picks the subject area. Right now, today, Board of Medicine physician licensee has to have 30 hours of type 1 hours every 2 years and 30 hours of type 2. They're getting ready to get rid of the type 2 piece. And then the board has got to publish this requirement. So they're saying of the 30 you got to get, the board can pick a subject area that they want to look at. You've got some other bills coming through the system and human trafficking and other things like that. And then a second enactment just to say the board, as they're looking at their subject areas to designate in that 30, implicit bias needs to be one of the first ones.
All right.
But that would be the amendment that I'm not technically able to offer to you, but maybe somebody on the committee would like to do that.
All right, we have a motion to adopt the amendment of the second enactment
Can
clause.
somebody read it since, again?
Mr. Chair, the full bill will now read, of the hours of continuing education required for biennial renewal of a license, any licensee of the Board of Medicine may be required by the board to complete up to 2 hours of type 1 continuing learning activities or courses in a specific subject area. If the board designates a subject area for continuing learning activities or courses, it shall publish such requirement no later than January 1st of the first year of the term of the license for which the specific learning activity or course is required. And then there'll be an enactment clause that states that if the Board of Medicine designates a subject area for continuing learning activities or courses pursuant to this act, one of the first subject areas shall be on the topic of implicit bias.
All right, Mr. Chairman, how does this differ from the bill? I don't see a difference. I'm missing something, I guess.
Mr. Chairman?
Yes.
I think that's a good thing, but it basically puts it under the auspices of the Board of Medicine, and it gives them the ability to pivot and do different areas of subject matter expertise over time as deemed priorities. But it's preventing us from creating code that is an endless Christmas tree of additional designated hours for physicians or other providers who already have a significant clinical requirement for ongoing education.
Well, my concern is the bill, I think, deals specifically with people who are pregnant or about to be pregnant. I mean, this said in the bill is fairly specific. This is just general.
If I may.
All right.
Mr. Chairman, subcommittee members, Nicole Pugar-Lauder on behalf of the American College of Obstetricians and Gynecologists. We did talk with the director of the Board of Medicine about this and explicitly asked that question, who would this include, what professionals? And so I was told it was 18 different types of specialties under the Board of Medicine that this would capture. So it's broader than just physicians that are treating, the way it's written now, that are treating women directly. And I would point out, in respect to my friends in the nurse midwife and professional midwife community, this doesn't impact them, and they do have direct contact with women who are birthing. So
My other question is, of the 18, does that include maternal issues?
it would not, no, sir. Yes. It would be, as Mr. Johnson alluded to, radiologist.
Yeah, okay. So it
Physical,
wouldn't,
you know,
so it wouldn't deal with the issue we're dealing with here?
Well, it would,
Well-
but it would also impact others. Yeah.
All right. We have a motion. Is there a second to the motion from Senator Donovan?
Is it this for the amendment?
Yeah, for the amendment, yes.
I'll second
All right. All in favor of the amendment, say aye.
Aye.
All opposed, no?
No.
All right, we have one no, but that motion passes, so that's.
I couldn't hear you.
We have one no, but the motion passes.
How did you vote? Did you vote?
I voted aye.
Yeah. All right. Is there anyone else to testify? So,
Hello. Hello, everyone. I'm Sylvia Budali. I'm a certified nurse midwife, and I'm representing the Virginia affiliate of the American College of Nurse Midwifery, and I just want to speak on support of this bill. It's incredibly important to get implicit bias training, I think, profoundly because bias and assumptions about people of color can contribute to chronic stress that impacts things like hypertension and high blood sugar that contribute to morbidity and mortality, of course. So going deeper and understanding these intersections and how even physical therapists and radiologists and chiropractors have a direct impact on these outcomes and the assumptions that are made and in the stress so many face when they're entering the healthcare system, we support implicit bias training.
all right, thank you.
Mr. Chairman, I have a question.
Yes, Senator Suderline.
I guess one, it might be two questions based on the answer to the first. The first is, where we are now with the amended bill, would midwives be required to have this education?
I think they are overseen by Board of Medicine, correct?
Yeah,
And I was just corrected, and
Yeah.
I apologize for that. I was
Yeah.
just conferring with my friends back there.
Yeah, the CPMs and licensed midwives are under the Board of Medicine, and then CNMs and CMs are under the Board of Medicine and Board of Nursing, so it would apply.
It was another version of the bill, and I apologize for that.
No apology necessary. Thank you.
All right, anyone else wish to testify? All right, the bill is before us, and it's an amended form. So,
Recommend reporting as amended.
okay, we have a motion. Is there a second?
Second.
Yeah, okay, we have a motion and a second to report the bill as amended, so. All right, call the roll.
Senator McPike,
Aye by proxy.
Senator Hashmi, Senator Pillion, Senator Suderline, Senator Donovan, Senator Edwards,
Aye.
Senator Newman, Senator Saslaw,
Aye by proxy.
Senator Barker,
Aye.
ayes 7, noes 1, abstentions 1.
All right. All right. Are there any other patrons? Okay.
Well, I've got 4. You do one.
Because I'm going to look at Stewart's bill and see if I can do that.
All right, because I think Sue.
I have one.
Billion, yeah, I'm happy. You want me to go?
Yes, yes.
Okay, go.
Thank you, Mr. President. Mr. Chairman. I am. I'm going to start with Senate Bill 1275. And, Mr. Chairman, this bill seeks to allow licensed midwives, and there's a substitute. Move the substitute. Okay.
For the substitute.
And the substitute really is just technical information that kind of rearranges how things are said so they're more clear, Mr. Chairman. But the heart of this bill is to allow nurse midwives who do not have prescribing authority, these are licensed nurse midwives, licensed midwives to possess and administer the medications that are on a short list, and I'm sorry I don't have that list with you, I should have had that, that are on a short list as authorized by their licensing organization, their credentialing organization. These are medications like the gel that you put in the infant's eyes at birth, a vitamin K shot, Pitocin for bleeding, other medications that really are an important component of safe childbirth, because you always have to be planning for complications. And as an OBGYN, I think this is probably a really good plan. It allows the list of medications to have safety regulations that are reviewed and set up by the Board of Medicine, who oversees licensed midwives. It asks the licensed midwives to participate in the Virginia Neonatal Perinatal Collaborative safety bundles, the most recent of which was on obstetric hemorrhage. So it's really kind of standardizing a little bit more what is, the general standard of care for childbirth, whether it happens in the home or happens in the hospital. We do have 1,000 births in Virginia that happen in the home each year. And then, of course, this bill precludes any medications that are on the schedules of concern. It's really just all safety medications that are involved in this bill. So I hope that explains it. I'm happy to answer questions. I think that there's good consensus on this bill, and we may have some people that waited all last week to speak to this bill and are here this week.
All right. Are there any questions of the patron? Yes, Senator Edwards.
I have a question. You have in here that an entity that provides a medication to a licensed midwife and relies in good faith upon the licensed information provided by the licensed midwife is not subject to liability for providing the medication. Why you put a lack of liability issue in here?
I think it was determined by LIS as we were writing, and best recommendations for this bill is it has been presented in code across the country. And I think that the liability protections are just kind of standard. I'm not sure I have, I think that's kind of a standard thing in dispensing.
All right.
I'm not sure it's standard,
Yes.
but anyway.
Yes, Senator Newman.
John raises a question that is kind of critical to me over the years. We've talked about how much we have. I'm not very. John has asked a good question, and that is over the years, the midwifery issue, always worried about liability, because we want opportunity, but do we have liability? And maybe there's a quick answer to John's question, but is this in all, do physicians have similar language? Why do we have this language in this particular bill?
Mr. Chairman, if I can respond, first of all, the indemnification is really for the dispensing organization, the pharmacy, the wholesaler. It's not for the midwife. Yeah, the midwives still have all their normal liability and have to have malpractice. This is just a protection for the organization that dispenses. We specifically wrote this bill so that there's no confusion about prescribing ability for midwives. They do not have it. They may possess and administer, and that often would require either a prescription from a physician that is sent to the pharmacy, or in some cases there are contracts that can be formed with a direct pharmacy so that they can have access to these medications. But the indemnity is for the dispensing pharmaceutical organization, not the midwives.
Right. Yes, Senator Newman.
Thank you. That helped on the one. When you talk about possess and administer versus prescribed, is the difference that you're not having them go administer themselves? Is that the difference between it? Is it that they have these drugs on hand and they can use them as needed, as opposed to saying, go get them? Is that the difference?
The difference is that prescribing requires certain levels of training and understanding of the side effects and education, et cetera, which is not part of what they do, but it is much more of a broad, prescriptive authority is over a much larger class of medications. This is a very limited number of medications that they can possess, things like antibiotics for a patient who's Group B strep positive. And again, the standards of care are very clear in when these are utilized and administered and how these are triggered. But something, for instance, Pitocin or another medication that you would need for hemorrhage postpartum. Part of the reason that we are including the neonatal perinatal collaborative training, which many of the hospitals across Virginia have implemented for postpartum hemorrhage, is that it does set up very structured guidelines of when to intervene and how to do so to protect life. I hope that answers. Yeah.
All right, Julia, you want to add anything to? Okay.
No,
all right. Yeah. All right, time to testify, so.
Thank you, Mr. Chair and the members of the subcommittee. I appreciate the opportunity to speak today on behalf of the licensed midwives and the Virginia Midwives Alliance. I'm Kim Pekin, and I'm a licensed midwife and registered nurse in Loudoun County, Virginia. I have been a licensed midwife since 2009 and own 2 nationally accredited freestanding birth centers. And I'm the chair of the North American Registry of Midwives, which is the organization that determines our scope of practice for the Certified Professional Midwife credential. And I previously served as chair of the Virginia Midwifery Advisory Board under the Board of Medicine. And I've dedicated considerable time to educating student midwives and working towards quality improvement for the profession in the Commonwealth. Our current midwifery law has not changed since 2005. It needs to be updated to reflect how midwives practice around the country. Virginia is one of only 2 states that license midwives, yet do not allow them to use the medications that are within their scope of practice. And we feel Virginia can do better than this. Virginia licensed midwives want to increase safety and improve the outcomes for the mothers and babies in their care. 47% of Virginia counties are maternity care deserts, where the length of time to get to the hospital creates a challenging situation for midwives and the families that they serve. For example, in the Northern Neck, it can take up to an hour and a half to 2 hours to get to the hospital. And so having things like oxygen and anti-hemorrhagic medications, which we currently don't have access to, it greatly increases the safety of mothers and babies in rural maternity care deserts. So, Senator Donovan was speaking to the medications. So the medications that we're talking about are things like if the mother were to tear or have an episiotomy during the birth, we need to be able to use lidocaine as a local anesthetic. We feel that suturing, yes, right? We feel that suturing without lidocaine is just inhumane. It's just not okay. And mothers, if they want to have the vitamin K for their baby or the eye ointment, they have to take their brand new baby to the emergency room, which could be 1 to 2 hours away after they've recovered enough to be able to travel to take their baby there. So most families just decline those state-required medications for their babies. And, we know that compliance will greatly increase if we have access to do that at the point of care. They must also go to the emergency room to get RhoGAM if their blood type is Rh negative, and that protects future pregnancies for their babies and future pregnancies. So many women decline the prenatal dose of RhoGAM because of the inconvenience of doing that. And postpartum hemorrhage is the leading cause of maternal death in the world. And so, we were just talking about maternal death. And if we want to do better with maternal mortality, it's important that all maternity care providers have access to the anti-hemorrhagic medications and IV fluids that make birth safer. And Group B strep, as Senator Donovan was talking about, is a leading cause of preventable death for newborns. Having the ability to administer penicillin according to the algorithms recommended by the American College of Obstetrics and Gynecology and the Centers for Disease Control and Prevention nearly eliminates deaths due to GBS sepsis in newborns. Our scope of practice includes certification in the American Academy of Pediatrics Neonatal Resuscitation Program, and part of the NRP algorithm is to administer oxygen to prevent brain damage due to hypoxia, and we're currently prevented from using oxygen. And we want to make sure that when we do need to transfer to the hospital, because that's part of what we do is we identify when we need to go to the hospital, we want to make sure that the hospital provider will receive patients who arrive in better condition because we've been able to use these first-line medications that would have been administered in the hospital had they been birthing there. So for the safety of mothers and babies, we ask for your support of this bill. Thank you.
Thank you. Please.
Chairman and subcommittee members, I'll be brief. Nicole Pugar-Lauder, again, on behalf of the American College of Obstetricians and Gynecologists, I want to thank the CPMs for working with us in the off-season to get to a really good place in this bill. Thank you, Senator Donovan, for your work on this bill. I think it really does protect mothers and babies, and it'll help us improve maternal mortality rates, so thank you. We support the bill. Sorry.
Hello again. I'm Sylvia Budali. I'm representing the Virginia affiliate of the ACNM. I am an advanced practice midwife in Richmond, and I am the legislative chair of the Virginia ACNM. I'm here to support this bill. We uphold this legislation both in support of the profession of our licensed midwife colleagues, as well as in support of clients seeking midwifery care across Virginia. I am a CNM, so I already have prescriptive authority, but I am employed by and work collaboratively with licensed midwives here in Richmond, providing home birth and birth center birth services. I'm confronted every day with the legal, logistical, economic barriers that licensed midwives face when it comes to providing care. I'm also reminded daily of the immense skill and expertise licensed midwives hold and the value that they provide their patients. Though I feel lucky to work alongside licensed midwives and offer medical management, that's currently a big part of my role in our practice, I know deeply that licensed midwives deserve autonomy to manage their care of their patients and have full scope of these incredibly important and life-saving tools to keep their clients safe. So on behalf of the ACNM, we would like your support for this bill. Thank you.
Thank you.
Good morning again. Sheila Herlihy with the Virginia Interfaith Center for Public Policy, and for the many reasons already stated, we support the bill. Thank you.
Thank you. All right. There's nobody else to speak. That bill is before us now.
Report. As amended.
Okay. With a substitute. Yes, yeah. All right. The bill has been, a motion has been made to adopt to report the bill, recommend reporting the bill with the substitute. Call the roll.
Senator McPike?
Aye by proxy.
Senator Hashmi?
Aye.
Senator Pillion?
Aye.
Senator Suderline?
Yes.
Senator Donovan?
Aye.
Senator Edwards?
Aye.
Senator Newman?
Aye.
Senator Saslaw?
Aye by proxy.
Senator Barker?
Aye.
Ayes 9, noes 0.
All right, thank you. All right.
Share the floor and keep going.
Keep going.
Okay. Mr. Chairman, next bill up is Senate Bill 1255, Smart Chart, and we have a substitute. Amendments, that's right.
Yeah.
And I have another amendment as well to add to the work group that I'll talk, a line amendment when we get going. Yep. Mr. Chairman, I will ask with these line amendments, and I can, they basically just help. They're really just technical amendments. They're not changing the intent at all. The line amendment would be to add to the work group in the enactment clause a private sector technology expert with experience in prescription data sharing and controlled substance monitoring. Would you? Thank you. And with that, I move the amendments.
Mr. Chairman,
Yes.
with a lot of amendments, it's better just to have a substitute. Just, can we roll it by then?
Okay, that's fine. Substitute would be great for full.
Put it in the calendar.
So, Mr. Chairman,
Yes.
move the amendments.
Okay.
Substitute, move the sub. Yeah.
Okay. Move the amendments, which will now be incorporated into a substitute. So, all right. All in favor say aye.
Aye.
All opposed, no. All right. It's before us in that form. So,
Mr. Chairman, this bill is the result of remarkable work by VHI really this year to look at something we asked them to look at last year, and that was how can we reduce the cost of healthcare in Virginia by making sure in a secure HIPAA-protected way that labs that are done at one location on a patient are available to other providers that see that patient across Virginia. And it was building on the concept of EDCC, Emergency Department Care Coordination, that's been going on for a long time. That came into play about 6 years ago when we interconnected, despite the obstacles of all of the EMRs, we interconnected all of the emergency departments across Virginia to allow them to know when a radiology test had been done at another ER or perhaps lab work. That was, and to develop some case management, to try and redirect patients that were, going to the ER for care that might be better provided in a primary care setting, to get that case management, to get them there. Some of the flaws with technology when we set up EDCC were that you knew that a test had been done at another emergency department, but you couldn't actually see it. You still had to reach out through the cumbersome process of signing papers and faxing and hoping you got it back. And this is the life of a provider in Virginia today. I see patients in my office, they come in and they're like, I had all these labs done and they said this and I want to know what you think and I had this ultrasound and I can't see any of it. And a lot of this is proprietary obstacles, but it's just not good patient care. And patients end up having to have repeat tests, repeat visits, repeat copays, and just delays in actually coordinating their care. What VHI was able to figure out was that with the system we have in place with EDCC and relationships that system has with innovative programs across the country, we now can develop a way where we can participate in a collaborative health information exchange. Those are a virtual place where labs can be sent, data can be sent and housed in a HIPAA secure way. They're very expensive. They're very, they're a lot of work to maintain and make sure that they're secure in the world of HIPAA. But the good news is we don't have to build our own, which would have cost us tens of millions of dollars in Virginia. We can participate in a collaboration with other states where there's a collaborative HIE already set up at a very reduced rate. And what we can do is we can use our established, data responsibility group, right now called the EDCC committee, that kind of oversees how this all works, for us to decide as we go forward what data do we collect. And how this is actually going to work is that doctors' offices will choose to participate. Hospitals already are compelled to participate, but they will direct the holders of their EMR, the proprietary entity that has the capacity to do this very easily, to drive the data that we determine we want, labs, radiology, and that will have to be processed and agreed upon. But the data that we want, as soon as a doctor or provider closes the chart, that data will go right to the HIE, so that when another providing doctor goes into the patient data on that patient, they will be able to retrieve that. And so with that, Mr. Chairman, we actually will be able to vastly improve the services that we provide, decrease cost, decrease duplication, which is the number one source of control of healthcare costs across Virginia. If you look at the articles that are out there now, there are a lot of hypotheses about how many tens of millions of dollars. We've had a hard time tracking with our EDCC because honestly we had so many things going on at once. But there's somewhere in the range of $25 million that EDCC has saved in repeat ER visits and repeat tests across the state of Virginia. So I hope that explains the bill. The enactment clause that's on the bill is a aspiration. Mr. Chairman, one of the major challenges that healthcare providers and hospitals have is medication reconciliation. We don't actually know what the patient's taking. They're not always good historians. The records are hard to track. And now with this new system of interconnectivity, the question is, can we find a reliable way to have a medication reconciliation? Because that, too, will go a really long way to making sure there's continuity of care, patients are complying. So with that, I'll stop, Mr. Chairman, and see if there are any questions.
All right, any questions of the patron?
And Mr. Chairman, just to clarify, there is a budget amendment for this. It's really small. I'm not kidding. It's a couple of $1 million. We draw down non-general funds to go with that, and that budget amendment is going to be utilized to, and that's all we need actually to implement this system. But that money is actually going to go towards helping medical practices shoulder any costs that EMRs direct are necessary in order for that data switch to be turned on to send it to the HIE. And if I've explained anything wrong, I have experts here that can clarify.
Anybody want to testify on this? No.
And this is a recommendation from the Joint Commission on Healthcare.
Right. All right. The bill is before us.
Doug wants to say something. When he's in favor of my bills, I really want to speak.
Amen. That's why I came up. She's done a lot of great work on this. The EDCC is a great project. We're not trying to get rid of it. We're trying to build upon it. Medicaid really funds the Medicaid lives in the EDCC. We fund the commercial lives, and we're all working together to try to do a better job of sharing information. But it's not easy. There's lots of information out there, and she's trying to make it simple instead of overdoing it.
Second the motion to report as amended.
All right, we have.
Just good about it.
Eventually.
They'll make that motion at full committee next week then. All right, we have a recommendation, a motion to report as amended with the substitute. So,
Senator McPike?
Aye by proxy.
Senator Hashmi?
Aye.
Senator Pillion?
Aye.
Senator Suderline? Senator Donovan?
Aye.
Senator Edwards?
Here, aye.
Senator Newman? Senator Saslaw?
Aye by proxy.
Senator Barker?
Aye.
Ayes 8, no 0.
All right, that motion passes. It'll be reported under the full committee, so.
I do have two more. Do you want me to skip me for a little while? You're tired? I'm okay with that.
I think Todd is tired, so.
Think
Yeah.
You want me to do mine?
Go ahead and do yours, Todd. So.
Well, you're definitely. That's fine.
Yeah.
There's an amendment that needs to be adopted, Mr. Chairman. Could do that.
Second.
Okay.
Motion and a second to adopt the amendment. All in favor, say aye.
Mr. Chairman, members of the committee.
Amendment's adopted, so.
Okay,
yeah.
all right. Mr. Chairman, members of the committee, the bill before you allows dentists to administer Botox for cosmetic purposes. It contains a requirement that dentists must complete training and continuing education as prescribed by the Board of Medicine and the Board of Dentistry. Currently, dentists are allowed to administer Botox as part of dental treatment, and routinely dentists use it for conditions such as sleep apnea, teeth grinding, tension headaches, and excess salivary flow. Medical doctors, oral surgeons, PAs, and nurse practitioners in Virginia are now allowed to undergo appropriate specialized training to administer Botox for cosmetic purposes, and about half the states, including our neighbors of Maryland and Virginia, permit dentists with training to administer Botox for cosmetic purposes.
We're in the Commonwealth of Virginia, sir.
Yeah, West Virginia, sorry.
Well, let's not confuse.
Okay, yes. No worries. Sorry about that, Mr. Chairman and Senator Suderline. Dentists already frequently administer precise injections and are familiar with the anatomy, of course, and physiology of head and neck, making them well suited to administer Botox for cosmetic purposes. And that's the bill before you. And I know there's several people here to testify for the bill.
All right, any questions of the patron? All right. Anyone wants to provide testimony, come forward, so.
Mr. Chairman, Scott Johnson is General Counsel for the Dental Association. I have the pleasure of introducing Dr. Cindy Sutherland from downtown Pulaski.
Okay.
Hi, thank you, Mr. Chair and committee members. I really don't have much to add. I am Dr. Cynthia Southern, and I am president of the Virginia Dental Association. We support this bill. Our neighboring states are doing this. Dentists are very well trained in anatomy and physiology of the head and neck. So we'd love to be able to do this and hope we can add it as a service to our patients. So thank you so much for your time.
All right. Anybody else wish to testify on this? We have a motion to report and a second, as amended. If there's no further discussion or questions, call the roll.
Senator McPike?
Aye by proxy.
Senator Hoshman? Aye. Senator Pillion?
Aye.
Senator Suderline?
To allow this in Virginia, yes.
Senator Donovan? Aye. Senator Edwards?
Aye.
Senator Newman? Senator Saslaw?
Aye by proxy.
Senator Barker?
Aye.
Ayes 9, no 0.
Thank you, Mr. Chairman.
Thank you.
Glad I got back in time to see that.
You want to do yours, or?
I
you want-
can, whatever you want.
Yeah.
Good morning, Mr. Chairman.
Yes.
This is Senate Bill 1070.
Okay.
Mr. Chairman, as you know, we have had a law in Virginia that basically indicates. Siobhan, can I have that right there?
Yes. Yeah.
That allows minors to consent for certain medical procedures. Nothing in this will change that. Mr. Chairman, though, there is a conflict in the Code of Virginia, and I would tell you that different agencies are treating the conflict differently, and I just don't think we know exactly how you reconcile two different sections. In some of these sections, parents are having trouble getting their minor children's medical records, and in other sections, the code is so clear that they do get it. This bill hopefully takes both sections and allows them to continue on as they are with some clarity. And let me give you an example. For instance, the portion that I mentioned before that allows minors the ability to consent to certain medical procedures, and they are very narrow, but this bill, as it is drafted now, allows that to continue. None of that is changed in any way. There is another section of the code that, if you read it, is so clear as almost you can't misunderstand it either, but it says that parents shall not be denied access to health records for their minor children. Well, this bill kind of allows both to move forward. So the bill clarifies the issue. It does not change that ability to consent where the code is very particular. It can consent, but clarifies that their parents may have access to their records. I imagine this committee could come up with a lot of reasons why we have that section of the code, but clearly there are health allergies, there's family history items, there's drug interactions, there's a lot of reasons why you would want to make sure that a parent could get that information. There is always in the Code of Virginia that some of you probably know, and it's a form of a safe harbor, and the safe harbor provision indicates that provider feels like there's any endangerment at all to the minor, then they don't have to do it. But that's a general provision. That's a general provision in HIPAA as well. Clearly, any federal items related to this always supersede, like HIPAA as well. Mr. Chairman, I think it's important that we have both sections, and this just makes sure there's clarity on that item. That's the bill.
Okay. Are there any questions of the patron?
Makes sense to me.
All right.
People responsible for these children
Yeah.
to know.
All right. Anyone want to testify?
Mr. Chairman, I have a question.
Sure.
Because I'm so sorry, my computer's down. I'm not sure I understand some of the nuance of what you said. Are you saying that parents will have access to all records, even the ones for which they're emancipated? And so, okay, without their signature?
So So I may have to ask about emancipation, that maybe so I may ask for help on that. There are sections of the code, as you know, probably now better than you knew even before, that allows a minor to make certain medical decisions without a parent's oversight, without full emancipation, right? Those would all continue, but all the medical records would be aggregated and a parent could be able to get those records. Yeah. Is that right? That's correct. Okay. Maybe you want to answer the question.
Yeah.
Yes.
Good morning, Mr. Chair and committee members. I'm Allison Tysinger with the Office of the Attorney General. And so what this bill does is for the categories of treatment that a minor is deemed to be an adult for the purposes of consenting to, it clarifies that a parent can access those records as well.
Can I ask a question? Oh, sorry. Can I ask a question?
Yes. You certainly can.
If a child is completely emancipated, in other words, he is emancipated, what happens?
I think if the child is completely emancipated, then that would cut off the parent's rights at that point, if it's an emancipation order from a court. So this bill is not addressing the emancipation.
Yes. Yes, Senator Donovan.
What is the practice across the country?
I do not know the answer to that. I imagine it varies, but I'm not sure of the answer.
And I would say, I would have to say with deep respect for the patron, this is really a cornerstone of making sure that patients can get care in bad situations. And, parental access to the records are as easy as the patient putting the parent's name on their HIPAA form. When they give me permission, when I ask who can share, and I'll be honest with you, many parents insist that children put them on the HIPAA form. But I think the way that we have it now, where there is the ability for a person to give permission but also have privacy in these circumstances, is a really important part of an opportunity for me to educate. And part of my education is actually talk to your parents. But I have a hard time understanding why this is a necessary change, and I don't think that this is the standard of care, that parents automatically have access to records across the country. I think the standard is that youth that are seeking, information. I'm so glad that in the code we have that parental notification for abortion, which I think is still in as I read all of the records. That's a different situation. That's a medical procedure. But I just, I feel deeply about protecting my patients. And in order for them to feel the ability to be seen and get information and be educated and maybe even prevent pregnancy, that I have to be there for them, and they have to feel that it's safe. And so I would love to hear more reasons why I'm wrong, but if this is not the best practice across the country, or there's a really good reason to do it, as a parent, I know I want that information too, but as a physician, I can't support it.
Mr. Chairman?
Yes.
We got to see it again next week.
I think we're not.
Thursday's our last.
Yeah, because we'll have Thursday will be the last full education and health before crossover.
Okay. I just want to answer that question because I know she's very knowledgeable about it. But I think we see, or what I'm hearing is that there are different agencies that treat this differently, and we don't have consistency, and we don't always know. And so we were looking for clarity, and I think you need either clarity on one side or the other. But I'll let it go through the process. There's always time between here and the full committee to work on that, so I'll just let you do your thing.
All right. Is there anyone else who wishes to testify? All right.
Nicole Pugerwater, again, on behalf of the American College of Obstetricians and Gynecologists. And we would just echo what Senator Donovan said. We specifically have some concern related to the automatic release of the patient record related to venereal and contagious diseases, STIs, STDs. We believe that parents have the right to the access, but we have to have that conversation with the patient individually and the parent individually to talk about the importance of the confidentiality of that record and the patient getting the right care when she needs it. So for that reason, I'm so sorry, Senator Newman, but we do oppose that specific part of the bill.
Yes.
I apologize for missing the support, but I hope you let me I'm Sherry's story, and I am speaking for the Family Foundation, and we support the bill.
Thank you. All right, anyone else wish to testify? Senator Newman. Yeah.
It's straightforward. The bill is
It does seem that this is pretty straightforward. It says, notwithstanding any other provisions of law, a medical record, and it deals with venereal disease, birth control, family planning, substance abuse, and mental health. So those are the four categories that have been.
You are right. It would do that, and I think there's the lack of clarity in each one of those sections, and this would add clarity. There may be people that like the lack of clarity, and maybe people that don't, but I tend to believe that parents are ultimately responsible for their children and should know about their care. This does not in any way restrict their ability to get the care, but we should trust them to know their care.
Right. All right. Is there the bill's before us? Is there a motion? All right, there's a motion and a second to report the bill. Then we'll do the substitute. Well, go ahead, and then we'll.
Senator McPike.
What's the motion we're voting on?
The motion is to report.
Okay.
Senator Hashmi.
Wait. Senator McPike votes no by proxy.
You have all the proxies?
Yes.
Senator Hashmi.
Yes. No by proxy.
Senator Pillion.
Yes.
Senator Suderline.
Yes.
Senator Donovan. Senator Edwards.
No by proxy.
Senator Newman.
To report.
Yeah.
Yes.
Senator Saslaw.
No by proxy.
Senator Barker.
No.
Ayes 3, noes 6.
All right. Well, I'm making a motion to pass by indefinite, to recommend passing by indefinitely, and I'll use Senator Saslaw as the seconder of the motion. So, call the roll.
Senator McPike.
Aye by proxy.
Senator Hashmi.
Aye by proxy.
Senator Pillion.
No.
Senator Suderline.
No.
Senator Donovan.
Yes.
Senator Edwards.
Aye by proxy.
Senator Newman.
No.
Senator Saslaw.
Aye by proxy.
Senator Barker.
Aye.
Ayes 6, noes 3.
All right. Thank you.
At the appropriate time, I think I can help with Senator Stewart's bill, but there are people here, so we'll let
Okay.
them.
Senator Donovan, you want to?
Oh, do you want to, that is Evans here, do you want to let him?
Oh, yes.
Thank you,
Certainly.
Mr. Chairman and members of the committee. This is Senate Bill 1090 dealing with our expanding the medical cannabis licensing program in Virginia. What it does is it adds an additional licensee in each with up to 5 retail locations and 1 co-located facility in each of Virginia's 5 health service areas, and it also bans moving forward, not retroactively, the acquisition of multiple medical cannabis licensees by one individual or entity. We know that patient access is essential for a robust medical cannabis program, and we got off to a slower start in Virginia. We have 36,159 registered patients, but only 15 dispensary locations that are open. That's 2,400 patients per dispensary. This has created a lack of geographic access, especially in areas like Health Service Area 3 in Southwest, where a patient would have to drive up to 3 hours in some cases to access medication. We know that Virginia currently has one of the lowest total dispensary numbers in any of the 29 states with medical programs. Florida has 27, Illinois 53, Michigan over 100, Montana has 50, New Mexico 68, Arizona 126. If this legislation were to become law and every processor had 5 dispensaries, we'd have about 50 dispensaries serving 8.6 million people with one dispensary per 172,000 people. So it's a pretty straightforward bill. We're basically doubling the potential over time for the number of medical dispensaries for cannabis.
Okay. All right, are there any questions for the patron? All right, does anyone wish to testify in this? Was it Senator Pillion?
Mr. Chairman, Senator Evans, this would be additional locations for the 5 original.
No. It would be basically there would be 5 competitors in a sense, or 5 additional in one in each health service area, and they could have satellite locations as well. Limited
So
number.
go from 5 to 10.
Right.
Right. Okay. Come forward, present your testimony. So.
Thank you, Mr. Chairman, members of the subcommittee.
Sure.
Chris McDonald with Williams Mullen on behalf of True Leave. First, I want to thank the patron for bringing this. I think that we've made really great steps in our current medical program, but as the program grows, it's time for it to kind of take more steps forward and evolve. As Senator Eben really astutely said, really this is all about patient access. As he noted, we have amongst the smallest medical program in the country when it comes to dispensaries and license holders. A lot of it is due to this kind of cap that's been put on one license holder per health service area. I'll just note, kind of adding to the data that he presented today, market research shows that really a market approaches saturation at about 1 dispensary for every 50,000 people. And under the current system, even if it's maxed out with the 5 dispensaries per health service area, we're still looking at 1 dispensary for every 345,256 people. So there's a lot of room to grow, and we think this is a pretty nuanced approach to it. I'll also just note, given some of the barriers to the current program, Health Service Area 1 currently has no processor whatsoever. That's tied up in litigation with no real end in sight. That means that currently and for the foreseeable future, there are about 1.37 million people across 32 localities that comprise HSA1 that have no real easy access to their medicine. Happy to answer any more questions, but again, I want to thank the patron for introducing this important legislation and encourage your support. Thank you.
All right, thank you.
Good morning, Mr. Chairman, members of the subcommittee. Hunter Jamerson, I represent Jushi. Jushi is the pharmaceutical processor licensed to operate in Health Service Area 2. We're based out of Manassas, so we've shared our concerns with Senator Eben, who's been a tremendous friend of the pharmaceutical processor program, and we continue to enjoy that great relationship, just disagree on the approach of the timing for expanding the existing medical program. As you've heard, we're down 1 health service area at the moment. There's only 4 of the 5 statutorily authorized pharmaceutical processors. Also, the General Assembly authorized 30 cannabis dispensing sites. Less than half of those are online yet. We have a long way to go to build out the existing programs that's currently authorized. The challenges we're facing getting patient access in the medical program are not because there aren't enough doors open. There are other bills before this subcommittee that identify those challenges, issues in the credentialing process, the regulatory management process in the program. But what we've observed in the medical cannabis space and in other states is that rather than taking an arbitrary number of licenses, we establish objective criteria by which we expand the program as the market demand is present. JLARC recommended to you all that there are 300,000 patients in Virginia's medical cannabis population, we presently service 50,000 of them. We're at 20% capacity. Again, that's not because of the number of doors open, that's because of challenges in the operation of the program itself. I know that the regulators, Board of Pharmacy, the future regulator, Cannabis Control Authority, have taken a look at what objective criteria could look like. Our recommendation to you all and request is that you send this bill to those regulators for review of establishing objective criteria when is the right time to expand the program. Thank you.
Thank you. Anybody else wish to testify? All right, the bill is before us. Yes.
Do you object to having those boards review the timing on this?
I would just say that we are so underserved, and the fact that this, by the time this bill takes effect and then licenses are issued, we're talking about years. I don't object to having it looked at, but I'm reluctant to have to wait another year to move forward.
Mr. Chairman.
Yes, Senator Donovan.
Are we underserved or under-accessed with only 50,000 patients seeking medical marijuana in the state of Virginia between 4 pharmacies? I hope that you'd be okay with having the boards look at this, because I don't disagree. I love the idea about competition, and I feel like we've throttled this too much. But I just think that we've got, obviously I have a bill that's going to hopefully open that up a little bit. But I don't want to undermine the investments that have been made without really seeing returns yet.
Mm-hmm. Yeah, I just think the number that we have for a state of 8.6 million people is not adequate, and probably won't be adequate in a year when, by the time these get opened. But, whatever the committee decides, the committee decides.
All right, the bill is before us.
Mr. Chairman, I'm just looking to see. Okay, I'm not sure I have the right bill. Mr. Chairman, I move that we refer this to the new cannabis board and the Board of Pharmacy to review the appropriate time for expansion.
Okay, so you would
recommend PBI with
okay.
I guess that is that a PBI with letter?
Yeah.
I'm sorry. I'm sorry.
You okay with that, Adam?
Second. Yeah. All right, we have a motion to pass by indefinitely and with a letter to the cannabis entity, and then.
And Mr. Chairman, I think that letter should say particularly to look at utilization of the process right now, because I know we're talking about how many Virginians there are, but they're not utilizing the program. But anyway.
Yes, Senator Newman.
Adam, I kind of like your bill. I don't like any of the cannabis bills, as you know, right? But if you're going to have it, then we ought to get to competition.
I agree.
So I hope they figure that out, because if they don't figure that out, I'm going to vote yes next time. Because if you're going to have it, it shouldn't be a monopoly. It produces poor results all the way around.
I agree.
Monopolies are bad.
Yeah.
Those are bad.
Yeah.
Especially for power.
Yeah.
Unless you're happy. I was just happy we got the video.
Yeah. All right. Is there a motion?
So moved.
Yeah.
I'll second
Okay.
the
Yep.
motion.
Okay. We have a motion and a second to pass the bill by indefinitely, and to recommend that. Yeah. Call the roll.
Senator McPike,
I will vote no by proxy.
Senator Hashmi,
No by proxy.
Senator Pillion,
Aye.
Senator Suderline,
Yes.
Senator Donovan,
Aye.
Senator Edwards,
No by proxy.
Senator Newman,
Aye.
Senator Saslaw,
No by proxy.
Senator Barker,
No. All right.
Ayes 4, noes 5.
Okay, the motion fails.
Reverse the vote.
We'll reverse the vote. I'll have Senator McPike make the motion, and then I'll second the motion. And we'll reverse the
Report the bill.
vote. To report the bill.
Without the amendment or with the amendment? Without the amendment, is that right?
Right.
Without the.
Right. Right.
Senator McPike,
Aye, by proxy.
Senator Hashmi,
Aye, by proxy.
Senator Pillion,
No.
Senator Suderline,
No.
Senator Donovan, Senator Edwards,
Aye, by proxy.
Senator Newman,
Abstain. I'd like to see work done.
Yeah.
Senator Saslaw,
Aye, by proxy.
Senator Barker.
Aye.
Ayes 5, noes 3, abstentions 1.
Thank you, Mr. Chairman and members of the committee.
All right. Are there other bills to be, other patrons who are here, et cetera?
I may be able to help with them. I don't know.
What's it?
You want to do Stewart?
Yeah, we can, yeah. All right.
Can I do it here?
Sure. We'll call up
Yeah.
Senator Stewart's
Yep.
bill.
Mr. Chairman, this is Senate Bill 1119. There's a substitute, and move the substitute.
So moved.
Is there a second?
David, second.
Yes.
Pick up down there.
All right, all in favor, say aye.
Aye.
All opposed, no. Substitute's adopted, so.
Mr. Chairman, this bill is Senator Stewart's bill. He was wishing that he could have been here today. It basically allows patients to have, that have established relationships with their practitioners, who is a member of the Health Maintenance Organization, multi-specialty group, to receive services from the practitioner who's a member of that multi-specialty via telecommunication without going back for an exam. This is individuals that had it before. Mr. Chairman, this basically, as I understand it, is a cleanup bill from the language that we had last year. It keeps in place the period of 12 months required between persons and examinations for the purposes of providing continuity of care for telehealth. I have more, but I will pause there and allow those that are in favor to speak in favor of it.
All right.
Mr. Chair, members of the committee, Michelle Satterland on behalf of Johns Hopkins. We wanted to thank Senator Stewart for carrying this bill. He's been a champion of telehealth, and thank Senator Newman for pinch hitting this morning on describing the bill. Just to be clear that the bill is really, as Senator Newman said, a cleanup bill. The substitute that you have before you is language that we've worked out with the Mid-Atlantic Telehealth Network and the Medical Society, so we appreciate their willingness to discuss and find a solution on this issue. It just ensures that providers who have seen a patient, when that provider is out and on vacation, has gone home for the evening, that patient has access to another provider who is within the same subspecialty and within the same group, so that they don't have a risk of not having access to care. It's a continuity of care via telehealth, and we hope that you'll all support it.
I think it adds nurse practitioners, and I think we should expose that fact.
Mr. Chair, thank you, Senator Newman. You are correct. The original bill and the bill that was passed last year said that any practitioner regulated by the Board of Medicine could provide telehealth services. We have narrowed that. That was 22 providers. It's now narrowed to 6 providers, which includes nurse practitioners. There was some question. As you know, nurse practitioners are regulated by both the Board of Medicine and Nursing, and it wasn't certain that they were included when it just said Boards of Medicine. So that has been clarified as well. I don't know of any opposition, but
all right.
Thank you.
Morning, Mr. Chair, members of the subcommittee. Ben Trainum with Hancock Daniel on behalf of the Medical Society of Virginia. We appreciate Senator Stewart working with us, and also Ms. Satterland working with us, and thank everybody for helping us get into a posture where we can be okay with it.
All right. Anybody else wish to testify? All right, we have a motion to recommend reporting. Is there a second?
Second.
All right, we have a motion and a second. If there are no further questions, call the roll.
Senator McPike,
Aye by proxy.
Senator Hashmi,
Aye by proxy.
Senator Pillion,
Yes.
Senator Suderline,
Yes.
Senator Donovan,
Yes.
Senator Edwards,
Aye by proxy.
Senator Newman, Senator Saslaw,
Aye by proxy.
Senator Barker.
Aye.
Ayes 9, noes 0.
All right, the motion passes. All right. Okay, go ahead.
Mr. Chairman, the next bill would be Senate Bill 1337. This is a bill regarding the current process for medical marijuana, and it does a couple of things to refine how things are operating. Probably one of the sentinel things is that it allows the creation of a medical director, a physician that would work with the pharmacy that could provide the authorizations that are now extremely expensive and an obstacle to, substitute. Lovely Julia. Yes, thank you.
All in favor?
Aye.
All right, all opposed? No. Okay. Motion is adopted.
Thank you, Mr. Chairman. It would preserve the physician oversight in making a recommendation for the dispensing by the pharmacist at the dispensary, but it would create a situation that would be less expensive and more access for patients. And I will tell you, Mr. Chairman, it has been great frustration to me. I have actually many patients that are pregnant that are using marijuana, and I keep trying to redirect them to medical marijuana, and the cash fee for the televisit to get authorization to get the medical marijuana is an obstacle that they really have a hard time overcoming, and they usually don't. And so when they're purchasing marijuana from wherever they are, there's no reliability of what is in that substance or how they might react to it. Of course, they're probably self-medicating, but they're very engaged in utilizing this medication. So I think where we can preserve that medical kind of throughput or gatekeeper, but, make it a little bit of an easier threshold for the patients, it would be great. They would be able to see the physician on site. They could use telemedicine, and so those are all ways that could happen. The other thing is that this has a little bit of process modification. We often have these kind of cleanup bills as we go along. One of the other things that's adding to the incredible expense of medical marijuana is the requirement for retesting for products. Because there's no tolerance for any variance, which, if you look at even generic medications, there's a considerable amount of variance in generic versus, brand name, and that variance is something that's tolerated. So basically, what this says is that instead of testing every single new product, if there's any variance of more than 15%, testing needs to be done. And so that's kind of a quick overview. I have some subject matter experts here that can go into the details if you'd like. I'm happy to answer any questions. I think there's peace in the valley on this bill, but I'm happy to, hear what people have to say.
All right, are any questions for the paper? All right. Anyone want to testify?
Mr. Chairman, good morning again. Hunter Jamerson for Jushi. I'm very appreciative of Senator Donovan for bringing this bill. I know she's seen a lot of hard situations in her medical practice as a result of folks who have not been able to access the medical program because of its cost and unfortunately turned to other sources that are not state licensed and subject to quality and testing and third-party certification. We support this bill. This bill does three important things. It addresses the bottleneck in patient certification in a way that retains the physician as the gatekeeper to the program, as you all have always instructed. Secondly, it improves the product registration process. This will be much more efficient, much more in line with other states in terms of, as Dr. Donovan noted, that important variance in how those are treated to ensure that the patient is getting a safe and quality product that's consistent, but that recognizes the practicalities of the production of medical cannabis. And then finally, the bill includes direction that the pharmaceutical processors must provide data to the Board of Pharmacy, ultimately to the Cannabis Control Authority, helping evidence that these changes are in fact making the program more efficient, driving costs down. We ask you to support the bill. Thank you.
Next.
Good morning, Mr. Chairman, members of the committee. Randy Pearson on behalf of Columbia Care, which is the licensed medical processor in HSA 5, the Hampton Roads region. We support the bill and thank the patron for bringing it forward. Thank you.
Thank you. Next.
Good morning, Mr. Chair and members of the committee. I'm Michael Johnson. I'm a native Virginian and co-founder of Dharma Pharmaceuticals, the HSA 3 processor. We thank Senator Donovan for bringing this forward and greatly support.
Okay, thank you.
Good morning, Mr. Chair, members of the committee.
Sure.
J.M. Padini on behalf of the National Organization for the Reform of Marijuana Laws. While we do support the bill, I would note that there appears to be two conflicting definitions in the amendment. In particular, we have what we would generally refer to as the current definition, which references 10 milligrams of delta-9 tetrahydrocannabinol per dose. And then
Line is that?
This would be line 30. And then on line 163, we have a strike-through of delta-9 tetrahydrocannabinol replaced by total. And as Senator Donovan might recall, we were intentional in originally codifying this specific to delta-9 because these products are so tightly regulated. We are not facing the same issue we would be in the unregulated marketplace where we're trying to capture all of these. By this restriction on total THC, then we would be eliminating the products that contain THCA plus delta-9 THC, which you would recognize from the nasal rescue sprays that are formulated for epilepsy patients.
We appreciate the we appreciate the catch, and so, Mr. Chairman, I propose we make that edit and strike the end of line 163 and 164 and return it to delta 9.
Okay. All right. Is there a second to that motion?
Second.
All right. We got a motion and a second. All in favor, say aye.
Aye.
All opposed, no. All right, that change is made. All right. If there are nobody else who wishes to testify, bill's before us, yes.
Why are we getting into advertising and marketing? I mean, they may have an additional right under the FDA or some of the FDA warnings, but it just sounds tough to have them getting into marketing and it be false, but I'm just, yeah.
I'm gonna pass that off to an expert because I would be guessing at that particular part.
Mr. Chairman, Senator Newman, I apologize, didn't hear your question.
My question is why the last part of the bill related to marketing? I mean, what do we, and advertising? Yeah.
Right.
Yes, sir. Mr. Chairman, Senator Newman, in lines 365 through 382, do not expand or empower us to market or advertise in any new way. Last year, General Assembly passed a bill that reformed the advertising parameters around this program, but did so in a way that directed it be done through regulation. Those regulations have been promulgated but are still not effective, and so this codifies the changes proposed last year as regulatory changes so that we can get them into effect. Yes, correct. Mr. Chairman, Senator Newman, as it stands, those regulations are still pending at the Attorney General's office, and so this codifies them so they take immediate effect. We're not waiting for the Administrative Process Act.
Mr. Chairman, thank you. Just in general, since the last bill, I don't like cannabis stuff any better than I did then. But I get that we need to get. I'm going to probably abstain, but it's not. I just am concerned about items that I don't know. So.
Right. All right. Bills before us.
Move to recommend reporting.
All right. I will second the bill, so second the motion. All right, call the roll.
Pike,
Aye by proxy. This is good bill.
Senator Hashmi,
Aye.
Senator Pillion, Senator Suderline, Senator Donovan,
Aye.
Senator Edwards,
Aye.
Senator Newman,
I'm going to abstain.
Senator Saslaw,
Aye by proxy.
Senator Barker.
Aye.
Ayes 6, noes 1, 2 abstentions.
All right. And I think we now are down to the last bill, which, oh, you got another one? Okay.
I apologize, Mr. Chairman. You have a very popular committee.
Yes.
Mr. Chairman, this is Senate Bill 1531, and it seeks to codify the Virginia Neonatal Perinatal Collaborative.
Okay.
This is, and it has amendments, line amendments.
Right.
So moved.
All right, second. All in favor, say aye.
Aye.
Opposed, no. The amendments are adopted, the line amendments. Thank you.
Mr. Chairman, we created the VNPC and code maybe 5 years ago now, and they are similar to 42 other states that have these entities. And basically, just to review, this is a collaborative of clinicians. Not any there are administrative representatives, but this is basically a clinically motivated entity that looks at best practices for perinatal and neonatal care in medicine. And it takes specific challenges we may have in Virginia, like, for instance, the one that they've done most recently was obstetric hemorrhage. And it promulgates best standard of care for that issue. And then it creates learning modules and best practice guidelines for all of those that are providers in the state of Virginia. What that does is where there are hospitals that maybe don't have the same resources as big systems, it gives them turnkey ability to improve their outcomes and reduce and really, create a best standard of care response to something like obstetric hemorrhage. We did it at my hospital. It requires drilling so that you practice. You actually have very set guidelines that looks, for instance, at where errors were made in medicine, like underestimating blood loss. So now you weigh the actual blood loss so that you can calculate at which point you need to do interventions. And across the country, these kinds of interventions have shown to significantly reduce maternal death and morbidity. So, Mr. Chairman, what this bill does is it creates code. It asks HHR to help them set up a contract so that right now they were first under Department of Health, then they were moved to VCU. They would like to be in a little bit more of an independent standing and ask VDH to help them negotiate. They have been drawing down a lot of dollars in grants. They take a very small amount of money from the state of Virginia. But one of the problems is when they're under an umbrella, often when you get a grant, you have to pay up to 30% of that grant to the entity, and they're trying to really put more dollars towards outcomes. And so HHR will look at developing best situation for them to continue to serve Virginia. Right now, they're working on what's called the fourth trimester to look very much at postpartum mortality for mothers and neonatal mortality. And this bill also requires all hospitals in the state of Virginia to participate in the collaboratives because not all of them have. And if we want to raise the standard of care, we all have to be on the same page with practices. So, Mr. Chairman, with that is the bill.
All right. Any questions of the patron?
So does it need to go to finance?
It will eventually, yes. And there is a budget amendment
We'll
with
make
it.
that ruling at next Thursday. So,
Yeah, I'm ready to make a motion when it's time.
If anybody want to testify on this bill, so you're worn out, huh?
All right, I move that we recommend reporting of the bill by the full committee and then re-referral to finance.
Second.
All right.
Thank you.
Call the roll.
Senator McPike,
Aye by proxy.
Senator Hashmi, Senator Pillion, Senator Suderline, Senator Donovan.
Aye.
Senator Edwards.
Aye.
Senator Newman.
Do you have his proxy?
Senator Saslaw.
Proxy.
Senator Barker.
Aye.
Ayes 9, no 0.
All right, that will be reported to the full committee. All right, yeah, the last bill is Senate Bill 1342, and this deals with anesthesiology. Just a quick overview, and then I'll entertain a motion. There are anesthesiologists who are physicians, and there are nurse anesthetists who are involved in anesthesiology. Many states, 20 counting the District of Columbia, have anesthesia assistants, and they are able to, in effect, help with the provision of anesthesia and to be able to get the throughput in terms of use of the operating rooms increased. We have some real challenges in Virginia in that there have been a lot of situations where hospitals had to shut down some operating rooms because they didn't have enough people to be able to staff it adequately and didn't want to risk the problem with the anesthesia. This is something that I think we need to move forward with, and I would have hoped to do it this year, but I don't think the dynamics have come forward in a way in another body that to get this added, but we'll try to address this again next year. And with that, I will make a motion to recommend striking the bill.
Second.
All right, we have a motion to strike the bill. Call the roll.
Senator McPike.
Aye by proxy.
Senator Hashmi. Aye. Senator Pillion.
Aye.
Senator Suderline.
Yes.
Senator Donovan. Aye. Senator Edwards.
Aye.
Senator Newman.
Aye.
Senator Saslaw.
Aye by proxy.
Senator Barker. Ayes 9, no 0.
All right. And that's it till next year, so, no. There, we'll take a few of those House bills, but they don't. Yeah.